you will hear.
Yeah.
Good afternoon. And today we have a pleasure of interviewing legendary Dr. Tasha Turzo. She's a founder and actually mentor on ALF approach. Good afternoon, doctor.
Hello. Thank you for the opportunity, and I'm excited to share.
And thank you very much to our audience. If you have trouble sleeping or sleep next to snoring partner, I'm sure you find a lot of wisdom from this interview, especially for the future generation. If you're a medical practitioner who, just like us, very passionate about patient health, and specifically in the area of sleep, this interview gonna help you to put puzzles of this disorder together. And let me introduce you Dr. Tasha Turzo. So she is, we have some dentists who talk about this field. We have some medical doctors who talk about this field as well on our channel. But this is very unique combination because Dr. Turzo, she's osteopath. And she work, I would say, in the dental area. She work in the mouth, as well as osteopathic manipulation. So she's connecting this part with the whole body as it's supposed to be. But, now in compartmental medicine, it's really rare find. So you're going to have that luxury today. So she graduated from osteopathic fellowship. And then she also complete family medicine residency. And then she's been in a practice since 95, practicing osteopathy, homeopathy, and functional medicine, prolotherapy, and specializing in craniofacial disorders. That's the main topic of our channel. And she is a founder of ALF. And she's the author of this great book, ALF Approach. And she has the course for practitioners who want to learn that approach. And I highly recommend it. Maybe that's going to be actually step into the future, at least in my book. This approach, it's a great approach according to my opinion, but in a general world, it has a lot of controversy. And we're going to discuss what it is and why, some people maybe not agree with the ALF approach. And my first question to you, how osteopathic principles inspire the creation of ALF, and what was initial intention of the design?
So Dr. Derek Nordstrom, he's a dentist. He's the one who created the ALF, and he's the one who created the initial design of the light wire ALF. And we worked together once a month for probably around 27 years in terms of perfecting and individualizing the way to adjust the appliances for each patient. So I didn't create the ALF appliance. I was more involved in helping to optimize the design and individuate the design for different patients. And Dr. Nordstrom, he studied osteopathy, and he saw the results we were getting when we were treating patients with cranial osteopathy. And he wanted to design an appliance where he integrated the intraoral dysfunction that creates crooked teeth. So osteopathy has three basic principles. One, structure and function are reciprocally interrelated, which means function comes first and creates the structure. So the functions interaurally create the structure of our palate and the position of the maxilla and the mandible. The second one, another principle, is that the body is one functioning unit. So I use the image of Gumby, who's very pliable, to express the oneness from head to toe of a fascial connection with everything working together. And that's not just musculoskeletal, that's also biochemical, endocrine and our immune system and our GI system, our cardiovascular system. They all work together, even though we have words to separate them out into different systems, but they're not separate. So this is a founding principle of osteopathy. The body is one function unit. Structure creates function. Function creates structure. So the river that moves through the riverbed creates the riverbed, and the body has innate capacity to heal itself. These three principles went into creating the design of the ALF and the approach to treating TMD, sleep issues, airway issues, and crowded teeth syndrome.
Can very fashionable topic now is a vagus nerve involvement, and how cranial adjustment and using the appliance can affect parasympathetic function and overall health. I personally witnessing it every single day. My patient come to me and I can say, oh my God, he's in such a sympathetic mode. Like I see it, I see in the eyes, I see in the, we can call them wrinkles, but I would say tight muscles for very young people everywhere. Botox would not help with that. It's visible. So how, ALF can help to activate the vagus nerve and make parasympathetic system work better?
It's a big question, and there's a lot to this. And so I would recommend, if anybody wants to really dive into this further, read chapter 6 of my book and, take my online course, because it's filled with a lot of very specific information, 11 hours, and probably geared more towards practitioners. But let me say simply that the design of the ALF, again, was created to allow the tongue to come up to the palate, which is the normal physiological resting position of the tongue. When that happens, that allows the mandible to come down and forward, right? So, and we're going to talk about some of the things like an immature swallow in just a minute, and that will also help to understand more the underlying etiologies of some TMD for some patients. So the ALF appliance basically, it allows the tongue to come up. It stimulates the tongue to come up, because the tongue to the palate is a reflex, and something has to go wrong when we're younger, somewhere between ages of 1 and 3, typically, for us not to have this integrated neurological resting position of the tongue up in the palate. So as the tongue goes up, we also have an increase in motion in our entire cranium. So there's 26 bones in the head. They all move. They're indigitated in a very specific way for a very specific kind of motion. So you think of it like this. And fascia goes from the outside of the scalp to the inside, and that becomes part of the membranes and dura that actually hold and support the brain. The reason why these are not fused is because it allows the protection of when we fall on our head to have a give, a flexibility, a compressibility. So with the ALF in, stimulating the tongue up, stimulating an up and back swallow, that is our inherent way that we drain our sinuses in our ears and also increase motion of our temporal bone. So the temporal bone houses the joint for TMD, so it houses it. When we have these subtle motions of external rotation, internal rotation, that not only allows the draining of the fluids, but also keeps the discs healthy, because there's no direct blood supply that goes to the disc, to the cartilage. Everything is dependent upon an expansion and a contraction, a motion, and that pumps and drives fluid arterial system into all of our discs, including all of our back disc also. So we have that. And we also, when the tongue goes up to the palate, it relaxes our temporalis and our masseter muscles. So this relaxes. The reason why is we have more of a support to the base of our cranium. And as that happens, these temporalis and masseter muscles can let go, because in a TMD case, they're overfunctioning. So we're always looking at root causes for each individual TMD case. Why is this person's masseters and temporalis overfiring?
No, this is such a beautiful explanation, and I really hope our audience maybe even listen to that a couple times, because even for me, it's whole quantum physics. It's a quantum physics flow of liquid. And to tell to my audience what I believe, what it's true, because most of the people come to me with a sinus infection and TMGD, temporomandibular joint disorders. So they don't have that organic release of the or flush of the liquid inside the sinuses or inside the nose, and then joint does not have enough support as well.
Mm-hmm. What's so phenomenal about osteopathy and why it makes sense to be coming from an osteopathic perspective to look at underlying root causes for crowded teeth and oral dysfunction is because it's a profession, it's a medical profession. So in the United States, you go through medical school. So I'm a medical physician, but we're fulcrum in the concept and understanding of function. So we look at everything from like, where is things not moving? Where is there lack of motion? Because motion is life and life is motion. Right? So it's not just about how do I move the teeth to reposition the condyle. It's also about what's happening inside the mouth that shifted the teeth in that position, or how does that relate to the neck, and how does that relate to the feet?
Yeah,
so
this is so beautiful.
Integrative approach to looking at oral dysfunction or craniofacial dysfunction.
I love it. Please tell us, you talk in your book a lot, and I'm sure on your course, about immature swallowing. I don't understand how come I meet people, 99% of them have immature swallowing. What happened during those first 3 years of the life, what they cannot swallow in a regular way?
Mm-hmm. So some of the causes could be that birth trauma. And I talk a lot about birth trauma because nobody else is talking about it. So I want to focus on something that I think the public and us practitioners should know about. So during birth, there's a lot of compression that can happen at the base of the cranium. There is less motion between the occiput and the first cervical vertebra. That's the first joint that this compression of birthing meets. And there can be shifts between the first cervical vertebra and the occiput. And there are 4 very important cranial nerves that come out of the occiput, basically, into the face and down the neck. One of them is the vagus. So we can have compression, and that affects the motion of the tongue, hypoglossal nerve. Mm-hmm. The hypoglossal nerve is so important to understand this, and people don't understand this. And I wish everyone did. I wish everyone knew how important it is to get babies treated osteopathically to make sure that that hypoglossal nerve is not being impinged. And we think a lot of these tongue ties when babies are infants are because they need to have a release of the frenulum, mm-hmm. that's underneath. But what it really is a very lazy, discoordinated tongue that doesn't know how to move because the hypoglossal nerve has been compressed and pinched because of cranial compression during birth. So that's one reason. And I think that's one reason why we're seeing more of this and there's many reasons why we're seeing more crowded teeth and retained infant swallow pattern. But that's one. Also bottle feeding can also cause it. So anything that disrupts the normal suck and swallow, the physiological process of the development, tongue ties. That's another thing. If we have a tongue tie, the tongue can't get all the way up. So what does it do? It's just going to go forward, right? Any sort of allergies or increase in lymphatic congestion in the face is not going to have the tongue more go forward because the tongue is working as an orthodontic appliance. It's our most potent orthodontic appliance there is. And that's the reason why if you go to a traditional orthodontist and you get your braces on, you pay all that money to get your braces on. If you don't wear those retainers for the rest of your life, 100% relapse. 100% relapse. And why is that? Because the underlying etiology and root causes for why that tooth is in that position is not being addressed. And why are teeth in a position? It's because of the tongue. So the tongue has got a lot of jobs. It needs to create oral volume. It dictates the shape of the palate. It moves teeth to open our airway. It stabilizes our jaw joint. So it'll shoot to one side or the other side, depending upon even torticollis, right? The tongue will go to the other side to try to upright the head.
Mhm.
It will also do that with jaw joint dysfunctions. So the infantile swallow is when an adult is still swallowing with the tongue going forward, called an anterior tongue thrust. And what will it look like? If you just look at the position of the teeth, you look at the structure, it will tell you what the tongue is doing. So you have your class twos, your open bites, your deep bites, right? You have the maxilla going forward. That's that tongue pushing forward. And why is it doing that? We have to figure that out. And that's how I approach looking at the dental occlusion, is what are the underlying root causes? What is going on here? What is the dysfunction that we need to integrate so that we can have a sustainable structure for a lifetime?
So basically, I don't know if you have any picture of ALF to show to people who don't know what ALF is, but with the ALF, basically, it's simulating the tongue job. And eventually, when ALF is removed, tongue have to be in the place of the ALF.
I don't have any pictures, but if you imagine a very light wire that's in an arch, you have an upper arch and a lower arch, and it goes in behind the teeth. So that's another thing, is that it's not visible. It doesn't obstruct the tongue in any way. Every single other, there's actually one other, but 99.9% of every single other orthodontic appliance inhibits the tongue from going up. And I understand that from a dental perspective, because the dentists want to have a sense of control, right? You want to have a control where the forces I'm pushing, With the ALF appliance, you have to do actually more education to understand how to bend the light wire in just the right place. And it's individuated. It's not turnkey. There's no metal bar that goes across. It keeps the tongue low. I do not understand, as an osteopathic physician, why anybody would put a metal bar across their palate. It brings the tongue low. It's a non-physiological force. So it doesn't, the ALF is created to mimic the same forces that the tongue creates when it's up in the palate. That is a physiological force, and the body knows how to work with that. And that's why we have patients who put ALFs in, and they have ALFs and their low back pain gets better. It's because
That's beautiful.
Yes, it's because it's getting the tongue up, and it's integrating reflexes that have not been integrating. It's changing the posture from the head down.
I want to go to the posture. You know, a lot of people come to me with a forward head posture. How ALF can help to improve the posture?
Mm-hmm. So a lot of it has to do with initially the tongue posture. If the head basically follows the tongue position. So if sideways, if my tongue is low, my head drops down. If I'm swallowing forward, my head goes forward. So there's a bob. You know, we swallow 3,000, 5,000, let's call it 3,000 times a day. If I have an anterior tongue thrust, which I did until I was 35 when I corrected it with myofunctional therapy, my head would bob forward like this 3,000 times a day. And what does this do to all these neck muscles? They get very, very, very tight. And I'm going to tell you a very fun fact. The fun fact is that these muscles, these anterior neck muscles, attach to your upper ribs. So people who have anterior tongue thrusts or retained infantile swallows, this gets pulled up, and that affects the blood flow down the arms. So I have so many patients who have cold hands, who have recurrent tendinitises in their hand, and it's because they have an anterior tongue thrust. So the answer number one is that if you have an anterior tongue thrust, you're going to have more head forward posture. The other issue is that again, this compression that happens at birth. I think that our bones are not as strong as they used to be because of our digestion and because of our soil not being as nutrient dense. Basically, we're less nutrient dense. Therefore, the compressions at birth have more an effect. If you have any kind of compression on the hypoglossal nerve, you're going to have suboptimal oral volume. Suboptimal oral volume means your head goes forward to open your airway. So anything that has affected oral volume, you're going to have an anterior posturing. And then we put inside what we all do on our phones, head forward posture, right? So all you have to do is walk around and start looking at everyone, and everyone's got their head down in this way. So that's not helpful. As we can see that the development of human beings, that we're getting to have more and more, retrusive faces. Basically, it's not just, we call it class 1 or, class 2, class 3, but the truth, it seems, is that we're all bimaxillary mandibular retrusive, meaning like we're not having optimal facial growth as we used to. And so we're tending towards more that head forward posturing, because we're trying to, even if you just do it on yourself, even if you just take your head and move it forward, you can feel that the space behind your tongue, between your tongue and your neck, increases.
Yeah. And my last question to you would be about pain in the jaw joint. A lot of people use ALF for TMJ disorders, and some orthodontists claim what people wear ALF for the rest of their life. How ALF actually help with TMJ, and should they wear the ALF for the rest of their life?
Well, there's no dentist necessary. No, that's too big of a sentence. The ALF is not created for someone to wear forever. Do some patients want to die with their ALF in their mouth? Yes. But that's because they want to, not that they were told that they have to. The goal of the ALF is to integrate the underlying root cause dysfunctions for craniofacial dysfunction, and including crowded teeth syndrome. So there is an end point to getting to that place. Now, I'm thinking about one patient I have. She's a young 20-year-old. She got hit in the side of the face, dislocated disc. She's had a locked jaw many times. I've done PRP injections into her joint to try to rehabilitate the disc, which we have, but she also has an asymmetrical ramus. So one side is longer than the other. And she does very well when she's in her ALF. And there's no way she's going to take that ALF out. Even if a dentist said to her, you shouldn't have that in forever, she's like, I function better with the ALF in. So important to know that it's not the ALF it's not part of the ALF approach to say that you have to wear this forever at all. There typically is an endpoint, but there's the rare occasion where patients have such a structural deformity that using the ALF is helpful for them.
But basically for them, ALF create that balance, what the muscles can relax.
So what happens is when someone has, I think this is how I think it helps. And I think that we have more to learn about how the ALF helps with specifically TMD, is that, first of all, you can't have TMD without having cervical issues and asymmetrical alignment in your neck. And also you have to look at, was there a torticollis from birth? Is the SEM okay? There's all kinds of muscles everywhere that are affecting the jaw. So we have to make sure that we're treating all of those and evaluating all of the muscles that can affect the entire head and neck and mandible complex. But what happens when someone has, let's just take this last patient, they have asymmetry of bony development, they're going to have a constant tongue thrust. And we can see this when we take our ALF out, we can see that it's bent in a certain way because their tongue is thrusting away to try to balance out the asymmetry in the face, because everything in the body revolves around the eyes being horizontal level, or else we get dizzy and fall over. Right. So that's one thing that the tongue is trying to balance out the base of the cranium in this way. So if you have rotations here, when you put the ALF in, it helps the tongue to go to the center of the mouth because of that reflex and because of the stimulation that it does. So it helps the tongue come up, and in that way, it takes away from the asymmetrical pressure that the tongue is doing, and it helps to balance out the base of the cranium. We have so many patients, we put the ALF in, and the back of their heads, if everyone just puts their hands on the back of their heads here and finds a little bumps back here, AKA your mastoid process, to see if they're level or not. Well, mine are not level because I have some TMD stuff that I'm still working with. So mine's a little bit like this, right? When you put the ALF in, it allows the tongue to go up and helps to balance out the base of the cranium in this way. And so what does that do? That would take the position of the joint that's right here and put it in a different place, right? So what most of the dentists are doing is coming from the forward perspective, the face forward perspective, and putting in splints to try to balance it out here.
Yeah.
What they're missing is all the muscles in the back and all the muscles underneath, and what the tongue is doing, what's underneath the tongue to create this.
Thank you very much. It's been really useful information, and I highly recommend to my audience to read your book as well as to take your online course, because, and especially if you're a practitioner, because after that online course, you can get on a mentorship program, right? And really learn hands-on how to help your patients with ALF. So thank you very much, Doctor.
Thank you. Thank you for the opportunity.